Hello everyone, my name is Ajay. I am doing my PG in Department of General Medicine at Pushpagiri Medical College, Thiruvalla. I am presenting a typical case of a dengue fever. The patient is a 32-year-old male. He is a right-handed by occupation. His presenting complaints are fever, myalgia of 1 week duration, slurring of speech, unsteadiness while walking of 4-day duration, and disorientation of 1-day duration. Fever was high-grade intermittent in nature, which was associated with myalgia, not relieving after taking antipyretics. Hence, he got admitted in a local hospital, where he was treated with a provisional diagnosis of dengue fever, as his CAR test of NS1 antigen was positive. And meanwhile, in the hospital stay, patient developed acute onset of slurring of speech and unsteadiness of walking of 4-day duration, and disorientation of 1-day duration for which he was brought here. There is no history of headache, involuntary movements, urinary or bladder incontinence, weakness of upper limb, lower limb, no history of facial deviation or other cranial nerve involvement, no history suggestive of sensory disturbance, rashes, bleeding manifestation, photophobia, phonophobia, nausea, vomiting, no history of travel, no history of dog bite exposure to other animals. Past history: there is no history of coronary artery diseases, hypertension, diabetes, dyslipidemia or tuberculosis. No history of migraine, head injury, otitis media or paranasal sinus infection. Family history: 2 siblings with a history of coronary artery disease in father and diabetes for the mother. No history of similar illness in the family. Personal history is having mixed diet, sleep and appetite was adequate. There is no addictions and no alteration in bowel or bladder habits. Drug history: that was nothing relevant. Hence, summarizing the history, we have having a 32-year-old male patient with no known comorbidities. He was referred from an outside hospital with a symptom suggestive of a dengue fever of 1 week duration. Now presented with complaints of acute onset of dysarthria, ataxia of 4-day duration, and altered sensorium of 1-day duration. And the differential diagnosis we consider at the point were acute viral encephalitis, especially that of a cerebralitis, meningoencephalitis, acute disseminated encephalomyelitis, metabolic encephalopathy, post-infectious demyelination. Coming to the general examination, patient was confused. He was not oriented to time, place. Pulse rate was 64 per minute, which was regular, normal in character and volume. BP was 130 by 90 mm of mercury in the right arm in supine position. Respiratory rate was 18 per minute. He was afebrile at the time of examination. There is no palorectal cyanosis, clubbing, lymphadenopathy or edema. His BMI was 25.7 and skin, hair, thyroid examination was within normal limit. Coming to systemic examination, central nervous system examination, examination of the higher mental function. Patient was conscious but not oriented to time and place. Speech dysarthria was present, which was more in type of a staccato type of speech. Cranial nerve examination was within normal limit. Motor system: there was normal bulk, tone and power. Reflexes: superficial was normal with the plantar bilateral flexor. Deep tender reflexes was bilaterally normal. Sensory system examination was also normal. Coordination: finger nose test, finger to finger test and heel knee test was impaired bilaterally. Gait: broad based gait with a tendency to fall to one side was present. Cerebellar signs: there was no nystagmus. Finger nose heel knee test was impaired bilaterally. Dysdiadochokinesia was bilaterally present. Rebound phenomenon was present, which was on the right side. There was no pendular knee jerk. Tandem walking could not be elicited. There was no signs of meningeal irritation and scalene spine examination was normal. Other system examination was within normal limits. Now, summarizing the systemic examination findings, we have a 32-year-old male patient with no known comorbidities. He was referred from an outside hospital with a symptom suggestive of a viral fever, that is dengue. It presented with complaints of dysarthria, ataxia, 4-day duration and altered sensorium of 1-day duration. The examination revealed altered level of consciousness, with a disorientation to time and place. Dysarthria, which was more in favor of a staccato type of pitch, with a normal motor, sensory and cranial involvement, with a bilateral cerebellar signs positive, and there was no signs of meningeal irritation. Hence we did certain blood investigation which showed an HP of 15 and PCV of 43, leukopenia with a total count 2600 with a polymorph of 38 and lymphocyte of 58, ESR10 and thrombocytopenia with a platelet of 70,000, SCOT 196, HCBT 92. Other investigations were within normal limit. And the dengue NS1 and IgM was positive, and the lepto PCR was negative, and the peripherous blood smear showed mild leukopenia with mild neutropenia, reactive lymphocyte and moderate to severe thrombocytopenia. And CSF after an LP showed 70 cells with all lymphocytes with a protein of 148, glucose 97, gram stain and culture negative, and PCR was negative for herpes simplex 1 and 2. And MRI taken which showed a diffusion hyperintensity with low ADC values in the splenium of the corpus callosum, and the differentials include acute stroke, reversible lesions in the splenium of corpus callosum, and the differentials were including encephalitis, infection and PRES. Hence he arrived at a diagnosis of dengue encephalitis because he has met all the criteria of dengue encephalitis. He is having fever with acute signs of cerebral involvement, and there is presence of anti-dengue IgM antibodies in the serum, and exclusion of other viral encephalitis and encephalopathy. Now coming to the discussion part, the clinical spectrum of the dengue fever can range from asymptomatic infection to dengue shock syndrome. Unlike other arboviral infections, dengue virus does not usually cause neurological manifestation. However, in the recent year, neurological manifestations of the dengue have been documented. The manifestations include encephalitis, meningitis, encephalopathy, stroke, and Guillain-Barré syndrome. Dengue virus it is of mainly 4 serotypes, which can range from dengue 1 to dengue 4. Usually presents with fever, headache, rashes, and hemorrhagic manifestation. The serotypes most frequently implicated in causing these neurological manifestations are dengue 2 and 3, and dengue is classically thought to be as a non-neurotropic virus. Main symptoms of the dengue encephalitis are headache, seizures, and altered level of consciousness. Typical symptoms of dengue fever like myalgia, rash, bleeding manifestations are seen in less than 50% of the encephalitis cases. Dengue should be considered in all encephalitic patients in endemic areas regardless of the presence or absence of its classical features. The criteria for diagnosing a dengue encephalitis include fever, acute signs of cerebral involvement, presence of anti-dengue IgM antibodies or dengue genomic material can be either in the serum or in the CSF, with exclusion of other causes of viral encephalitis and encephalopathy. MRI findings in dengue can vary. MRI may be normal, but hemorrhages, cerebral edema, and focal abnormalities involving basal ganglia, hippocampus, and thalamus can be seen. MRI can also show extensive lesions involving midbrain, cerebellum, thalamus, and medial temporal region of both sides. And the take-home message from this case is common infection in the routine clinical practice that can cause fever with altered sensorium in a country like India includes cerebral malaria, herpes encephalitis, and pyogenic meningitis. And dengue encephalitis should be considered in DD of fever with altered sensorium, especially in countries like India where the dengue is rampant. Physician must have high index of suspicion, or else this uncommon manifestation of the common disease can be easily missed. Thank you.